goals. Thank you. Just to comment that this meeting is recorded, so please be advised of that in terms of the POPI Act, that there's a recording made of this discussion. The immediate goal of care and treatment should address distress, if this is part of the person's presentation, and also the barriers to participation in everyday life. And I think that is where a lot of the debate happens. Does the interventions we do really relieve the distress? Or does it cause more distress? Or does it cause a different type of distress? And does it add or remove barriers to participation? Hormone treatment, for those, the WPATH talks about 3 types of interventions, so-called fully reversible interventions, the partially reversible interventions, and then the irreversible interventions. And my own thinking around what is fully reversible intervention, what is partially reversible, and what is irreversible also evolved over time and in my involvement in the care. So in general, the WPATH guidelines say that the psychological / psychiatric intervention is fully reversible, because people can change their mind. They can think about things in one way, they can think about it in a different way. And that's what we do in psychotherapy standard, is that people change their mind, change their point of view. The hormone treatments to some extent is partially reversible. And the thinking is that should you stop the hormones, that the effects would reverse to a greater or lesser degree. Now, I think there's a problem in that thinking, and I'll highlight that a little bit later in the talk. But then the surgery is an irreversible intervention. That leaves the question of social transfer. When I started off, I thought, well, social reversible intervention, but in my view, it's a partially reversible, if not an irreversible intervention. So bear that in mind as we talk through how the different interventions contribute to the social transitioning. So I see there's a comment, and I wonder if we should, yes, the signal's intermittent. Can everyone hear me, or do I break up?
Gerhard, now and again you break up, but I'm not sure there's much we can do or that you can do about it, other than keeping your video off, of course.
I've got the best connection that I can find at the hospital. Petrus, thank you for your comment. If I do disappear, or thank you very much, Bongiwe. If something's not clear and you'd like me to repeat that or put it in the text box, I'm quite happy to do so. So the thinking around hormone treatment is that there are 2 types of hormone treatment. The one is puberty blockers. The other is then feminizing or masculinizing hormone treatment, which I would then refer to as hormone treatment, or HT. So the conventional thinking was that puberty blockers allow the youth, the adolescent, time to think. Usually the start of hormone blockers would be at the onset of puberty. Our guideline is to start at development at stage 2 development. But that puberty blockers would then also become the gateway to hormone treatment for those adolescents or those youth that would like to continue with HT, and that this is partially reversible. Whereas masculine or feminizing hormone treatment would facilitate social transitioning, so it'd make it easier then to fit into a social role of male or female. It then parallels puberty, and it improves a good outcome. And if your good outcome is the ability to pass as a trans man or a trans woman, and that is something that I would come back to later in the discussion. So, right. So the finding of the CAS review was that no change in gender dysphoria or body satisfaction was found with the use of puberty blockers. that there's insufficient and inconsistent evidence about the effects of puberty suppression on the psychological or psychosocial well-being of the youth, the cognitive development, the cardiometabolic risk, and fertility. And so the way that I read this is that there's no proven beneficence or benefit to using puberty blockers. And I have to mention here that the case review, as part of their oversight, commissioned the University of York for an in-depth review of the available literature, and this is the conclusion that they draw. So you may agree with this, you may disagree with it, but this is what they found, and I'm merely stating what the case review said. We can look at the situation in South Africa. Moreover, the majority of young people started on puberty blockers, then proceed from puberty blockers to HT. So there's no evidence, and it happened also fairly soon after the use of the puberty blockers. So it's not as if there's years between the puberty blockers and the onset of HT. And so there's no evidence that puberty blockers actually buys time to think, where the young people would be in a gender fluid state, or in a period where they would consider alternative states. Now, the concern here would then be around psychosocial development, gender identity development, and also good outcomes. The assumption was that puberty blockers leads to good outcomes, but we don't have evidence, according to the case review, of this actually being true. So one, again, from an ethical point of view, wonders what is the benefit, what are the risks, and how does this enhance the autonomy of a young person if the puberty blockers is merely a gateway to hormone treatment for the majority of youth. But that's certainly my personal experience in our transgender service, that most of the, and I must also then say that we have a selection bias, I guess, in our service, because the people who enter our service come explicitly so that they can access puberty blockers, hormone treatment, and ultimately surgery as well. So what happens outside of the service is open for debate. At least in our service, there's certainly a rapid progression from hormone puberty blockers to hormone treatment, and then with a view to surgery. Okay. The next topic is then feminizing or masculinizing hormone treatment as treatment for suicide. And so the suggestion's been made that hormone treatment reduces the elevated risk of death by suicide. And it's very well known from the literature that there are disproportionate increased rates for suicide in the transgender community. So I've given here a summary of 5 studies from 1997. Van Kesteren study that there's a disproportionate number of suicides in the Dutch transgender women, and the Dutch model was a very strong template for the WPATH guidelines. Pfafflin and Junger in 98, and just look at those statistics. So they looked at 13 European countries. The suicide rate under the transgender community in that study was 800 per 100,000 population for post-surgery transgender individuals, compared to 11.5 per 100,000 of the general population. So that is an enormous increase in the suicide risk. Dixon in 1984 found suicide attempts in somewhere between 19 to 25%. And again, this in the further community studies, lifetime suicide up to 30%. So somewhere between 20 to 30% on the best available literature. And then Xavier suggested that suicide attempts were more frequently under the youth. So the risk factors for suicide in the broader LGBTI plus community, so this is not only for the transgender community, but for the broader community, centers around demographic factors, and then young persons specifically involved in the demographics of suicide, increased suicide risk. The issue of stigma, prejudice, and discrimination plays a role in suicidality and suicide risk. And so the debate was, to my mind, if we start with hormone treatment and puberty blockers early, then we decrease the risk for stigma and for discrimination and for bullying, because we have better outcomes. We help the person transition, do a social transition, and it should reduce the stigma. The issue of minority stress, and at the last SASOP meeting, we had an excellent presentation around minority stress and how it relates not only to the LGBT community, but translated into the risk for mental illness and the risk for suicidality and suicidal behavior. The issue, this was in the study there, was the burden of HIV and AIDS, and how that contributes to the risk of suicide. And then lastly, increasing mental disorders. And I think that's a very important point, and I'm going to come back to that perhaps what we're seeing is not increased risk in the transgender community, but because of increased rates of mental disorders, that then translate to the increased risk of suicidality. This is a more recent study in 2003 by Mate, and they looked at the population of 73 transgender respondents compared to heterosexual females and males, and psychosocially matched females and males. And they found that significantly more transgender respondents reported suicide ideation and attempts, but that these attempts were linked to reports of psychotherapy and psychiatric medication, as well as the use of substances, drugs and alcohol. So it could be that mental disorders and substance use is a mediator for the increased risk of suicidality. Now, this is a contentious comment, and it's open for debate, and I'd like to hear other people's views on this. But I think there's a very strong move to depathologize or de-psychopathologize transgender or gender dysphoria or gender incongruence, and that a lot of the trans community and the trans activists, at least the ones that spoke to me, take great exception to, psychiatrists and mental health care workers being involved, because they think it's that we're doing gatekeeping, we're being accused of being gatekeepers. And it's certainly true that being transgender in itself is not a mental illness. But I do think that there's a risk of increased depressive symptoms and anxiety. We know about PTSD that links through various types of abuse, substance use disorders, and that could be the mediating factor. And so I think our focus should be, when we render service, to screen for the presence of psychiatric disorders, mental health disorders, and substance use in this group. So the findings of the CAS, or the conclusion of the CAS report, was that hormone treatment reduces elevated risk of death by suicide, but the evidence does not support this conclusion, the available evidence. The issue of detransitioning, again, is quite an emotive issue, and it's been politicized as a reason not to provide transgender care to the youth. So what does detransitioning mean? That's part of the problem. What do we mean when we say detransitioning? So there's a strong link with regret. So some transgender individuals regret starting the transitioning process and then detransition. So reverse all the changes they've made, whether that would be social transitioning or hormone treatments, or then even surgery. Other individuals regret the medical intervention, but they continue the hormone treatment just because of the difficulty of detransitioning off hormone treatment, whether that's for medical reasons or for the social transitioning. Other individuals do not report regret, but report that they would prefer not to have started with the hormone treatment, or they postpone the hormone treatment because they are not sure, they're not fully committed to the transitioning process. Others considered that medical treatment, including the hormone treatment, was inappropriate and in post-surgery, and that's a significant risk if we do these irreversible interventions, and patients or the family, well, particularly patients then, would turn around and say, actually, I think this was inappropriate. You shouldn't have done this. And that brings the whole area of autonomy in a vulnerable group where we deal with young people who may or may not change their mind over time, and then turn around and say, but you as the medical professionals are to blame because you should have advised me, you should have protected me against inappropriate interventions. And then lastly, there are some individuals that claim that they are no longer transgender, and we'll talk about the reasons for that in a few slides later. So it's been suggested that it's a small number of transgender individuals who do transition, but what does a small number mean? So the WPATH in SOC 7 writes that transitional reversal are rare. Rosenthal, 2021, talks about rare cases of detransitioning and quotes figures of 0.6% of transgender women and 0.3% of transgender men. McNamara, 2022, very recent data, also says that regret is rare and also refers to only 0.3% of individuals. Alt in 2022 wrote that the risk of regret is incredibly low without giving an exact figure. And this is from Cohen's study, Cohen's overview. Now, this is a very busy slide, and I'm not going to talk through all of it, but what I want to illustrate here is the difficulty of defining what detransitioning means and the numbers that we are talking about. And when this happens, does it happen post-surgery? Does it happen after the gonadectomy? Does it happen with medical intervention, or only as during the social intervention, as you see there in the Van der Busche study? But the conclusion of Cohen in this paper is that the true rate of detransitioning is unknown. Now, I'm not aware of any data in South Africa that talks about detransitioning in the South African context. My own experience, we have not had one of our patients since I've been involved in the process that detransitioned, but I have had patients who express regret, and I think it's because we, in our service at least, have a very rigorous screening. We don't deal primarily with transgender youth, and so I think there's a lot of factors that's at play there. It's a very long process, and so patients who do not complete the process, the surgical transition, they fall out along the way, and they just detransition by default, if I could put it in that way, by not continuing to surgical transitioning. But I'm not aware of the rates of detransitioning in South Africa, in particular under South African youth. So if anybody has data, I'll be very interested in hearing that. So the potential reasons for that would be a re-identification with natal sex, and that again is part of development as a adolescent. Difficulty separating sexual orientation from gender identity, and I think that is a particularly difficult situation. Let me just go further because I think it speaks to that issue later in the slide. Some of the reasons given, at least to the CAS review, was that the transgender was precipitated by
Gerhard, not sure if you can hear me.
Trauma, including sexual trauma. And so that there underlying psychological process, mental illness, of individuals struggling with their sexual orientation, and it kind of mutates into a gender identity, where a person says, well, it's unacceptable for me to be homosexual, but if I'm a different gender, then it's not unacceptable because I'm actually then attracted to the gender that I should, or the sex that I should be attracted to. Internalized misogyny, again, is a potential factor. And then what is highlighted in the CAS review is the influence of peers, social media, and online communities. And I think we shouldn't underestimate the impact that this has, at least on the identification and the late identification. So it's certainly been my experience that the patient or the members of the transgender community that I deal with knew very early on in their lives that they can't verbalize it as being transgender, but that they are different, that they don't fit in with their peers, that they somehow follow a different path. And it's only late in their life that they can say, well, I'm transgender. And the issue that's referred to here is this kind of late onset where adolescent girls would then say, I identify as transgender. And the concern is that that's driven by peer pressure or online communities. So the CAS review mentions here that people regret, but they might be hesitant to engage with the gender services that supported them, and that the specifications need to be adapted to provide detransition pathways. I think the last comment there is more particular to the NHS as a system, but I think this also speaks to our services that all individuals who present with gender incongruence and dysphoria, who want to transition, detransition, or retransition, should be carefully monitored in a supportive environment, especially when coming off hormone treatment. And I think that again speaks to not doing harm, to non-maleficence as a principle. What about hormone treatment? So there's a lack of high quality research assessing the outcomes, and particularly the long-term outcomes of hormone treatments. There are few studies that undertook long-term follow-up. There's no conclusions can be drawn on the effects of gender dysphoria, body satisfaction, psychosocial health, cognitive development, and fertility. And I think that is very important, which I'll address a little bit later. Uncertainty around height and growth, cardiometabolic, and bone health. So if we think about beneficence and non-maleficence, what we see here is that we don't have evidence of beneficence. We are not sure about non-maleficence here, about the long-term effects. It may be harmful, it may not be harmful. We just don't have the information. And then the last sentence there, and that's also a recommendation of the CAS review, is that where hormone treatments are offered, it should be part of a research protocol. And I think that's a controversial recommendation. We can certainly talk about it. So initially, the recommendation, and I think that's also part of WPATH, is that hormone treatment should be made available from age 16, puberty blockers from earlier, and surgery only at the age of majority, then in South Africa at the age of 18. So the review actually came out in recommendation 8 and said that the option to provide hormone treatment from the age of 16 should be done with extreme caution. There should be clear clinical rationale for providing it rather than waiting until the age of 18. Now, again, I think that's a contentious point. Even the author of the review writes in her introduction that some transgender youth might be disappointed by this recommendation. Some activists might be disappointed, but that's the best available evidence that the University of York could find. Recommendation 10 specifically talks about all children should be offered fertility counseling and preservation. Now, we have tried to do fertility preservation. I'll be interested to hear the experience in the Western Cape, but that's exceedingly difficult and costly, particularly in the public sector, to do that. And I think the concern here is that the way that people, and including members of the transgender community, the way that you think about parenthood when you're 12 or 13 or 15 could be markedly different from when you're 25, markedly different from when you're 35. And so to do an intervention that dramatically alters the fertility of a person, that could potentially be irreversible at a very young age, is dangerous, to say the least. And I think it's something that deserves careful clinical consideration and discussion. Another recommendation is that each case should be considered for medical treatment in transgender youth, and specifically should be discussed. They talk about a national multidisciplinary team, and that there should be a review as well. Now, we certainly in our service work in a multidisciplinary group. We've been criticized for that before, but we find that extremely valuable to work as a MDT and to have a collaborative decision rather than a single individual clinician making a particular decision. The last issue I want to address is the idea of better outcomes. But what are better outcomes? And I think this is where the values then come out. So would a better outcome be to relieve the stress, and particularly in emotional distress? Will a better outcome be to pass? But that's again in a binary context, to pass as a trans man or a trans woman. I've had clients of mine who said, once I've had my hormone treatment, the surgery, I will no longer call myself a trans woman. I will be a woman then. So I will then identify fully as a woman. But again, that leaves us in a binary space. What then about gender fluid or gender non-conforming individuals? Is a better outcome to fit in with my peers, to fit in with the community that I live in, who may have very different cultural and religious views on what it means to be a man or a woman, to fit in that community. Would the outcome be to improve mental health? We don't have the evidence that hormone treatment improves mental health, that it prevents suicidality. Would a better outcome means to improve overall health? What then we say about cardiometabolic risk, bone density risk, and long-term risk around fertility? And then the issue of fertility then comes into play here. So the case review, to quote it again, medication is binary, but the fastest growing group, at least in the NHS, is the so-called non-binary group. And we know even less about the outcomes for this group. So what is a good outcome for somebody that's gender non-conforming or non-binary? We don't know what the sweet spot is when people settle into their sense of self, or which people would benefit from medical transition when making these life-changing decisions. What is the correct balance between keeping the options flexible as you move through the treatment? So here are some of my conclusions. This is what we don't know. We don't know what transgender youth wants or need on an individual level, because there are different needs and different wants, and those wants and needs can change over time. We don't know what the benefits of puberty blockers are. We don't know whether feminizing or masculinizing hormone treatments actually prevent suicides. We don't know what the long-term outcomes of these hormone treatments are. And we also don't know what better outcomes for each individual outcome look. And that also might change over time. So what do we need, in my view? Well, first of all, I think we need to be open-minded, flexible, but also committed to an evidence-based medicine approach. And I think that speaks to the principle of distributive justice, that we treat our patients and also ourselves just as we treat any other patient, that we want to have evidence-based treatments, that we want to do no harm, that we want to benefit our patients. And we want to do that in a scientifically sound and defensible way. We also, in the same vein, want to individualize care. And I think it's very rare that you find a field of medicine where individualized care is so prominent, because we cannot have a one-size-fits-all approach to transgender youth care. It just does not work in the system or the needs for individuals. This must be collaborative care, in my view, as opposed to the current toxic environment where there's name calling and putting down of colleagues and activists, and a very acrimonious relationship that develops. I think if we start from a point that we all want the best for the individual and we work from there, we should then elicit the underlying values that we hold. I think this should be part of ongoing rigorous research. That's the report or the recommendation from the case review, at least. And I was thinking in preparation of this talk, how do we take it further? If we're committed to this and we say that we acknowledge we don't know and that we want to be scientifically rigorous and we want to be safe, how can we then, as the providers of care, take hands and join in collaborative research going forward. I think we should be mindful of the ethical principles, and we should also be aware of our own bias or biases. We all come with a particular background. We all have it from a particular religious or religious background. One thing that I've learned of the people around us. And Hilary Cass starts the Cass review with this quote. I want to end my presentation with this, that medicine's ground state is uncertainty. We know that. We deal with ambiguity and ambivalence every day. The wisdom for both patients and doctors is to find by how we cope with this uncertainty. And with that, I'm opening it back up for discussion, and I'm happy to listen to your views. You're welcome to disagree with me, and I hope we have a open and mindful discussion. Thank you very much for your attention and for the opportunity.
Thank you so much, Gerhard. You know, as you started off saying, this is a very contentious subject, so I think it's very brave of you to step into this space. But, you know, given that you've played such an important leadership role in South Africa, I think it's also important that you do so.